welcome again here. Of course, obviously some of you stayed. So we are now continuing along the lines of Digital Health Joint Vision for European citizens and patients. And another element that has been highlighted in this Digital Health Society Declaration and is also discussed, let's say, at many places in Europe right now, is both big data, of course, which is across many sectors. In healthcare, this is both about patient access, as we had it, is managing health data. But secondary use of data means a very broad and computerized access to large numbers of electronic healthcare records, which in turn imply some elements of privacy, security, pseudonymization, anonymization, and all these things. And the Estonian presidency brought up this concept of data donorship, which would mean that as you could donate, let's say, your body today, you will donate, of course, much easier. You donate your data and open it to all types of research. Those who are a little bit familiar with the subject know that the privacy issues along this use of data for research is a little bit complex, since giving consent always means that you know what you are giving consent for. And you have these, if you open it up for everyone, it normally is in contradiction with the concept of giving informed consent, because you have, as I say, giving consent to everything. And so the concept of data donorship may be a way out of this, let's say, riddle. So it's now my pleasure to invite the speakers. We have Veli Stroetmann representing today the European Institute for Innovation through Health Data in Gent. But she's also working for Empirica in Germany and has very experienced eHealth researchers for many projects. It's then my special pleasure again to welcome Aina Vikso, who is the Deputy Secretary General for e-Service and Innovation in the Ministry of Social Affairs in the Republic of Estonia. And so I've already cited some concepts that we understood from the declaration. We will then have Sebastian Semmler from the TMF, the Technology Methods and Infrastructures for Networking Medical Research organization in Berlin. He will speak to us on the German Medical Informatics Initiative, which brings in together medical care and research on in the future on a very large scale. Then Oliver Maaßen from University Hospital in Aachen will speak to one particular project out of this medical informatics initiative. And last but not least, we have Michael Strübin. He's a Program Director Europe of the Personal Connected Health Alliance in Brussels. And he will speak to us on work that is being done by the Personal Connected Health Alliance under the headline Getting Data in Shape at the Source. And depending on what I've now given to you is a sequence of the program as it should be. I'm not sure whether it's on the screen there, but it should be also online like this. If you have earlier versions of the program, you will note that we changed a little bit the sequence of the speakers, so don't be irritated. Good, so let's start with Veli. You're already there, and introduction has been made, so we're looking forward to your presentation.
Thank you. Thank you very much, Stephan, for the introduction. Improving care and research at the same time, win-win situation for health data. That's the title of my presentation. I will introduce you to a new European Institute for Innovation through Health Data. You see the logo in the right upper corner. And apologies that the name is so long, but the topic is complex, as you all know, so we struggled to come up with something really short, and that was not possible. Good. Treatment needs are changing. Of course, I only show this to you because of the requirement that follows from this for new, safer, more effective medicines in areas, different areas. And with the increasing pressure, of course, on healthcare budget, there is a need to focus more and more on best practice care and provide politicians with clear statements of value of interventions. This is directly related as well to the cycle that you see here of the so-called learning health systems, aligning clinical research and healthcare needs, but also opportunities through reuse of clinical data, data integration, and its use for enhancing medical knowledge and further supporting clinical workflows. And because a few years ago, actually a long time before that, but a few years ago, we saw the clear opportunity for convergence of healthcare and clinical research needs, which also is a convergence of opportunities for both. For healthcare to improve quality and safety of care, to support patients in self-care and maintenance, improve efficiency of care, etc., but also for clinical research to optimize clinical research processes, for faster and more accurate patient identification, for instance, and to enhance the access to the so-called real-world data. We saw the need to improve access to combined health data from diverse sources across Europe. And you have seen pictures like this, I guess, many times before. This is just once again to present to you the different sources that we mean here, where the data come from. Now, there are also common challenges, as we all know, to the use of health data for person-centered care and also reuse for clinical research, starting as usual with privacy protection issues, ethics, security when you want to access this data, but also quality and interoperability of health data in order to be able to learn from this data. And we had presentations about this, and we will continue talking about interoperability also in this session, and as I said before, demonstrating value in order to be able to transform healthcare. Now, we discussed with a number of stakeholders for years all those clinical and healthcare needs, and decided to focus on all those 6 topic areas that are listed here: best practices in information governance, solutions for better quality health data and legitimate uses of data, quality assessment, certification, etc., areas for which we decided to establish the European Institute for Innovation through Health Data. And it has been formed on the basis of several large European projects supported by the European Commission. Is a non-profit organization registered in Belgium to guide and catalyze the best, most efficient and trustworthy uses of health data and interoperability for optimizing health and knowledge discovery. This is the overall aim. And you may think there are so many initiatives, so many institutes, why this one in addition? But we saw this as a complementary, neutral non-profit organization which was needed to play a central role in defining governance and rules and promoting adoption of healthcare standards in this domain, and in particular about health data quality, a connector between the worlds of healthcare and clinical research standards, and promoting to society the importance of using health data for different purposes. And I will again focus on the neutrality of this institute. The institute is not supposed, and don't expect it to do many things that are listed here. It's the experts that are working on all those different topics that we have networked in this multi-stakeholder, very large collaboration, and the Institute is supporting them and is fostering sharing of lessons learned, agreeing on common practices, developing enablers, and supporting the whole communities, and in particular demonstrating value from the use of health data for healthcare, for patient society, and to research. Now, the main goal is to do everything to support assuring public trust when reusing electronic health record data for research. And for this, we have developed governance principles. There is a task force working on information governance. I will leave all the slides, of course, for download later on. I didn't want to delete many in order for you to see the whole picture, what the Institute is doing, like it has developed a quality seal for research platforms, for clinical research platforms, and it is available, this quality seal. It is doing a lot on interoperability, and the semantic, especially semantic interoperability priorities are also listed here. It has established a European network of excellence for hospitals and networking it, actively supporting hospitals to improve data quality, for instance, and working on assessment tools to help hospitals improve the data quality in all these 9 dimensions listed here, and also work with them on incentive strategies for data quality improvement, and also on strategies how to convince hospital management to focus on all this, and also provide evidence and real value, and assess financial and non-financial implications in order to realize, as I said at the beginning again, the personal health paradigm and also the learning health systems, which are all critically dependent on interoperable big health data. And I will end my presentation here. Thank you very much.
Okay, thank you, Veli, also for rushing through this really complex presentation. And I understood that it will be shared with the audience so people could have a second look at it. Thank you very much again, really very informative. We have a short session and 5 speakers, so let's go on. So now my pleasure again to invite Einar Avixo to the stage. He has already spoken this morning more on the political dimension of the overall declaration and the perspectives. Now he will speak to us again on, as already mentioned, concretely on this concept of data donorship, a pragmatic concept for big data. And we are really looking for your contribution, Ein. Thank you.
Thank you. Thank you once again. I'm actually speaking, filling the slot of a colleague of mine who fell ill last week, too much so that he said he wouldn't be able to present. So it's a shared vision that I'm in front of you with. And I honestly say that when I previously was speaking from the position of a civil servant responsible for EU presidency in certain area, which is eHealth. Now I'm really talking as an individual passionate about what you're going to hear, so I'm sorry if I get excited about it. So you have heard this, but I know that this is actually not that new concept, that data is the new oil. First, it was said by Clive Humby, which is a marketing consultant, and transformed in this way the online marketing, and not just marketing, actually how goods and services are sold. But interestingly so, just 3 years later, EU Commissioner on Consumer Affairs grasped this and also made it vocally as something that drives our understanding what will shape our future. Now, there is also an extensive book written by OECD a few years ago, and there is a paragraph or chapter about how the innovation will change, how the innovation stemming from healthcare will change it. And the main problem is that we even don't know how this will change. So some of the references made by Veli is that it's very difficult to consent people to something that even the researchers don't know how and what will happen in the future. So a big part of this my story tells that this patient engagement is pragmatic, because it can't be that in the old times with the clinical research, you got the data and then you work with the data 3 years, then you published it, and then at some point it became a knowledge, and then everybody had forgotten already the individual who donated the data. These days, this engagement has to be very, very operational. So. And then comes the question, who owns the data? I know lawyers, probably, please raise your hand who's a lawyer in this room, right? So, I'm good today, because I usually get in quite heavy debates with lawyers, because for them ownership is a very specific notion. But I try to tell how I understand being trained as a medical professional and not really a lawyer. As the people, I mean, if I go to a hospital and they suck blood out of me, and then they make that biological data into numbers, so suddenly that moment it changes who owns this. I can understand that this hospital needs to have this information so that in 20 years' time they can, confirm that I was actually there and everything they did was correct, and they can also need to bill for my services to health insurance. But the true data is about me, and it can't be, in my view, in any other way than the full control of that is on people. Happily so, there is an agreement at the European level which will set into force next May, that the data protection regulation very clearly tells that it does guarantee free and easy access to your personal data, making it easier for you to see what personal information is held about you, but also transfer that data. So privacy means not that we should seal the data from being used for whatever reasons and explanations we give, but actually make sure that it is used securely. Now, I've shown this slide already today, so I will skip through it pretty rapidly. But if somebody starts questions, do I think or do we think this is actually relevant to the citizens? The short answer is yes. Let's get over from that discussion. There is no question people want it. Not everyone, but those who want it we owe them to give them this opportunity. So what does it take? Now, Estonia has been praised, and I'm really happy for that we have found certain ways how to do that. I know many other countries have found their ways. So it is not the one legal framework or the one technology which will get us there. It's the combination of the legal framework, which fits our culture and traditions, then the technology. We can do that with our mobile or digital ID, but we're also experimenting already with blockchain technologies. And I know that we can do certain things in the legal framework, which we currently have, which we can't do with the old technology, but we can do that when we apply that different kind of technologies. So it's actually deciding that we want it and then finding the solutions to that. Few simple principles that we have established in Estonia. First, access to my data is something that we don't question. I can control who else can see my data. I can delegate that right to, could be my relatives, but it also can be a researcher, but it can also be a company who is using my data to develop new products and services. And the last bit is very important. It is not that I give this right away and then nothing is ever reported back to me. Currently, I can see who has accessed my data, and I was happy to hear that, for instance, Cancer Registry in England is preparing a solution whereby, at least on an annual basis, everybody whose data has been used for research purposes gets a report back. We can do that now in digital form. What kind of research projects your data has been used for? And believe, or so, it is so easy to link that information with actual publications. So each individual can be proud that they have contributed to a science article. And maybe at some point we can give people, honors for actually contributing to a Nobel Prize winning work. So this is the engagement, what I mean, if we actually don't take people as just blind donors of data, but actually participants in this relationship. And yes, it will change the world quite a bit. There is already examples. This one comes from the United States. I know there are a few others whereby patients who are not happy with the research and the solutions by pharmaceutical companies which have been developed for them collect data by themselves, and they turn upside down the business model. It is not that they will be recruited for the research. It is that they recruit researchers and companies to develop services for them. So this is what we can do if we truly empower the patients. Now, this doesn't come by magic. Also in Estonia, the trust that we are enjoying, that people are willing, and the red curve shows you 70–60% of people are willing to combine their data, including genetic data, health data from all different sources, and put that into use for research purposes. But see, we started from 18–16%. So it is gradual trust building that comes over time. So if your country or your region is not there yet, doesn't mean that your people are different. It just means that you need to convince them that you can deliver them back value, and that means that you offer them what is in it for them. And to finish, well, this slide was already showed, so I can skip it through. This is just tilted, I believe, 90 degrees. The slide that Veli you showed. What means that when the care flow is combined with the knowledge flow, and this is not anymore two separate domains, this is what happens and takes place on everyday places in hospitals. And if you are as enthusiastic as I am, please join another task force from the Digital Health Society led by Angela Brand. Very nice, extremely knowledgeable people working on it, how to make this happen. Thank you.
Okay, now it's working. Okay, thank you again for this really insightful presentation, and I can really confirm that Angela Brandt, the chair of this task force, is really a very nice person. She's again at Aachen, because they are close by. It's Maastricht, so you have not to go too far if you are interested to join this task force. So. We will, maybe I would allow one question if there's someone, but otherwise I would like to rush a little bit through because we are tight, and I know that Sebastian, or we have agreed that we will keep the time also to enable Sebastian to leave on time. He has an early flight. So I will immediately pass over to him. He will now switch to the German Medical Informatics Initiative, both, let's say, on the higher level, course, Sebastian represents the secretariat of this work. He will explain, of course, himself, and then we will later on move to a practical example. So, Sebastian, thank you for joining us.
Thank you, Veli, for the kind invitation and the kind words in the beginning. It was very interesting, the talk before, especially the sentence, data should be secured, but not secured from being used. I think that's a message, and exactly this is the message we are following in the Medical Informatics Initiative, which was established by the Federal Ministry of Education and Research. These are the aims of this funding scheme of the Federal Ministry. We want to improve the research opportunities in patient care. We want to intensify exchange and sharing of data. And this is important not only between the different institutions of the research community, but also between research and healthcare. That's the main goal of the initiative. And we want to foster the medical informatics field in Germany, fostering teaching and education in this field. And the Ministry for Education and Research decided to have a funding for nearly a decade from now on. The first funding phase will be 150 million euros, and we have the privilege to coordinate this with some partners, STMF in Berlin. To go into the details a bit more, the structure of the funding scheme is the following. There should be university medical faculties, university medicine sites working together, building consortia, and they shall build up data integration centers which will integrate the data from the healthcare sector and from the different research projects. And they shall make better the data, establish quality management processes from the patient care sector, from the beginning of the data capturing processes to the usage in the research field. That's a very, very big ambition. And there shall be developed modern and dynamic IT solutions for this field and some other activities. And we have support projects on the national level with a national steering committee. So each of the different consortia, I just will present to you, have a delegation in this steering committee, and that they decide together the next steps of this initiative. So this is the structure of it. The timeline is that we have, in the beginning, we have a so-called conceptual phase. So there were different consortia writing concepts, but at the same moment agreeing upon exchange data formats about procedures of working together. So they have a competition as a research project, and at the same time a collaboration to establish national structures. And we just are at the end of this conceptual phase, and then we will have two phases in the funding scheme with funding for the establishing the IT infrastructures for this data integration. At the beginning, we had 7 consortia across over Germany. I don't want to go through the names because of the time, but to have a look on the map of Germany, you will find that nearly every university medicine site in Germany was participating in this conceptual phase in different consortia. And in July, they had presented their different concepts to an international reviewing panel, and 4 consortia of these 7 are getting funded and were positively evaluated. And this is the situation now. You have 4 different colors, and these are the consortia which are at the moment at the beginning of their funding for establishing these data integration structures. What they are doing in detail, I don't want to mention, because the next talk by Dr. Maaßen, you will get presented it in detail about the first steps of one of these consortia. One important point is on the right side on the slide. It's the game is the goal is that all the other university medicine sites will be incorporated again within the next 1.5 years. So it will be again a national initiative of all university medicine sites in Germany and their partners in their regions and in their research fields. One of the major challenges was to establish a national collaboration and to achieve especially interoperability, but also a legal framework which allows to use data the same way in Bavaria and North Rhine-Westphalia and in Berlin, for instance, because we have a law on the different state level in Germany, and we have some different legal situations, and we have to get harmonized solutions to establish a process across over Germany, and we are working in different working groups together on the national level in the steering committee to establish solutions. And I don't want to go into detail. You see, it's a lot of work which have been done and which will be done in the next years in different working groups. We are working on a broad consent for the usage of patient care data for research purposes. We are working on the procedures of data sharing between all these sites, and especially we are working on interoperability. And at the moment we have a harmonized broad consent template. We are just in the negotiations with the data protection offices in Germany. There are 16 on the state level and 1 on the federal level. And we just starting this. We had already finalized the discussion with the different ethic committees in Germany about this broad consent. We have established common use and access rules for data sharing, which will be implemented in the next years. And we have agreed upon a roadmap on interoperability. And there are some crucial elements which will foster the interoperability movement in Germany at all. We are just starting at the moment with implementing LOINC as a coding scheme in all the labs in the university medical sites. We are preparing an introduction of SNOMED CT in Germany for this purpose. And we are very active in harmonization of documentation, even in the patient care sector. We have some lacks of documentation in the universities and differences in the documentation, and we have to agree upon how to establish a core data set. This as an element which in every site, in every consortium, we will have this core data set as a basis for data exchange later on. And also there is, at the end of the next phase, there will be an international audit, and we are working very intensively on the audit criteria for this audit. These are the most important aspects of this medical informatics initiative in a glance. The perspectives is we want to move ahead towards interoperability. We want to move ahead to more usage of clinical data. We want to set an impulse on standardization and interoperability in Germany, and we want to establish a new dialogue and partnership between industry and academia. And which is very important is that at a very early stage there's a very intensive dialogue between the Ministry for Research and Education and the Ministry for Health. We are already talking about working together using the structures which are established in the telematics infrastructure in Germany. So there is, in a very early state, we have a very intensive discussion about collaboration between research and the telematics infrastructure in the patient care sector. That's at the moment. Okay.
Thank you indeed for rushing this a bit through. Okay, I didn't say it in my introduction, but I think that's that's in this field the digitalization initiative in healthcare, I would say, and it's actually it's about this extremely important element. If you run big data analysis, really to have also coded data. Data coming from healthcare, and this is really a very complex project, and we are really thankful that you have brought this to this audience. because it also I think it also demonstrates that the theme of digitalization has already gained momentum in significant areas. So I think that's a very good starting point. Okay, we'll invite for questions after the presentation of Dr. Maaßen. He will now present the Smith collaboration, which you may have noted it was already on this slide with the 7 initiatives. It was the one on the bottom. So Dr. Maaßen, looking forward to your presentation. And please also keep the time.
Yeah, thank you very much for the introduction. I'm very happy and glad to present the Smith project to you today. And yeah, the Smith project, that's not only me, but in the Smith project, many members participated to write the project proposal and are working together to build up data integration centers. On this slide, I just have some of the members. This is the project coordinator, Professor Löffler from Leipzig University. Professor Fleig, he's the CMO of the Leipzig University Hospital. There are 2 CIOs on it. That's Mr. Henkel, Mr. Lovic, and from Aachen, our project manager, Professor Marx. All in all, every CIO from the university hospitals and as well also the executive board was involved in the project and is involved in the project. And beyond that, many and numerous project members from industry are involved. Here are our partnerships and cooperations. We involved the partners from industry very early to make sure that the project will be sustainable. And beyond the project partners from industry, several companies and health insurances and non-commercial associations gave us letters of intent and will cooperate with us. What does SMIS stand for? SMIS stands for Smart Medical Informatics, Information Technology for Healthcare. The conception phase ended in April 2017 when the SMIS consortium and 6 other consortia handed in their project proposals. The key features of the SMIS consortiums are we do have a strong network of industrial partners and research partners also, and actually we do have a very great team spirit in this project management team. We have use cases in the field of intensive care medicine and also in the field of antibiotic stewardship, which do have a direct impact on patient care. We do have a very standardized structure of the data integration centers, which makes it possible to roll out these data integration centers to other hospitals and to other university hospitals. We do have the SMIS marketplace, which is unique because it enables us to roll out our data integration center as well as our products which are developed in the project to other university hospitals and hospitals. Finally, in July 2017, the SMIS consortium was informed that we will be funded with 35 million euros for the next 4 years. This is the development and networking phase which was mentioned earlier. Besides the SMIS consortium, 3 other consortia are funded. This is the Future, the HIMED, and the Miracom consortium. Okay. Some information about the data integration centers. The data integration centers, one moment. The data integration centers will be set up at every university hospital, so Jena, Aachen, and Leipzig will build up a data integration centers. The data integration centers enable us to share data, to collect data, to share data in an interoperable way. We collect data in the data integration centers from diverse source systems like hospital information system, patient data management systems, and laboratory information systems. I will not go into technical details, but the data integration center is built upon common technical standards like EHE and HL7. For the data integration centers, we have 3 head of DITs. In Aachen, it's Dr. Haferkamp, Dr. Ammon for Jena, and Dr. Thomas Wendt for Leipzig. We have established 3 use cases. One use case is the phenotype pipeline. This is a methodological use case which is built upon natural language processing on EMR data and enables us to establish algorithms for phenotyping. The second use case is in the field of antibiotic stewardship, and it's called HELP. This stands for Hospital-Wide EMR-Based Computerized Decision Support Systems to improve outcomes of patients with bloodstream infections. The interface of the use case HELP as well as the interface ASIC, as well as the use case ASIC is the Smith app. I will go more into detail for the ASIC use case. The ASIC use case takes place on intensive care units. The problem is that you have many data on intensive care units, but you do not have those data when you need them. So you cannot have a view on every patient in every second. So we developed the ASIC use case, which stands for Algorithmic Surveillance of ICU Patients. We have three goals. We have 4 goals. First, we connect our source systems. This is goal 1. Goal 2 is we present data to the doctors from similar cases, so you can combine those patients and the cases. Goal 3 is that we will apply machine learning and establish an early warning system for critical states of patients. Finally, we have systems medicines which allow us to simulate the results of interventions. So you have the possibility to enable doctors to simulate the results of interventions for individual patients. So you can see what happens if you choose one way of treatment to the patient. The last key feature of our Smith consortium is the innovative rollout concept. We do have the Smith marketplace where we connect, on the one hand, the further university hospitals who will be connected to the marketplace, and it's a central contracting platform for internal and external data consumers and providers. So, what are the next steps? The project will start at the 1st of January 2018. We're looking forward to improve interoperability of data, the use of data for research and patient care, to strengthen medical informatics in Germany, and to cooperate on the national level. Finally, we want to roll out the Smith products to other university hospitals, regional hospitals, and GP networks. All in all, Smith is ready to go.
Very much, Oliver Maaßen, and I think we could just add that it builds on already running projects. So in the ICU, so you are not just starting it; it's a continuous process and progress. So thank you again for your inspiring presentation. Okay, we open now for questions for the first 4 presentations, since our first speaker, Sebastian Semmler has to leave in a few moments, and then we will continue with Michael. But are there any questions from the audience? Okay, if this is not the case, I think then we continue from fairness principles directly with Michael. Okay. Let me introduce Michael Strübin again. He is, as already mentioned, he's the European Program Director of PCH Alliance. PCH, but of course, sorry, I will not steal your own introduction as we had it last time. Nevertheless, the PCH Alliance is a profiling organization which looks upon actually how can we get neat data that goes in all those analysis whose principles the principles have been demonstrated by EIN, now by the Medical Informatics Initiative, and also by Veli on the level of the European Institute. So please add your part of the game, Mike.
Thank you very much. Thank you, Stephan, and thank you for all the presenters before. It's really heartening to see that that interoperability of data is on everybody's minds. May I just first see a show of hands? Who's heard of the Personal Connected Health Alliance? There are a few people here. That's wonderful. So I don't need to tell you that we're also the successor organization of an organization that used to be called the Continua Health Alliance. We're now the Personal Connected Health Alliance. We're the maker of the Continua guidelines, and I'll speak a little bit about that. A quick slide, though. We're not just about Continua. We also now run an annual event, the Connected Health Conference, which runs every year now in Boston. We just had our first, actually the 9th event, but the first one in Boston a few weeks ago, and it was really nice. And of course, one thing that you probably want to be aware of is that we're a part of HIMSS. This is the PCH Alliance membership, some of the leading companies and organizations that are our members. Our membership is separate from HIMSS. There are a couple of organizations that are both a member of HIMSS and the PCH Alliance, but we function as a separate entity and we have different goals. Let me talk first about the field of connected health. So obviously connected health, it's all around us in the area where we actually have a little stand in wearable technologies and elsewhere, and also in the fields of medicine. You need these connected health devices. They're all around us. They can be consumer devices. They can be medical devices. And it's really important that we get the data right at the source. Unfortunately, and I'm showing you this slide with a little bit of trepidation because I thought I'd put a couple of names on it, but really I don't mean to shame or name any organization. I could have picked any company out here that makes a medical device or a personal health device and then connects the device with an app and with a cloud. Everybody, nearly half of the organizations, companies that are exhibiting in this hall here have this kind of business model, but what results here is a field of walled gardens where data remains stuck. Data remains stuck in silos or in walled gardens, and data can't climb out. The culprits are both the device makers that take data, medical device makers, but also the makers of consumer devices. They like to keep their data to themselves. They like to keep the customer to themselves, and are very hesitant to share this data across standards, across the field. And where this business model or this situation serves many of these companies just fine. If I talk to people about open standards, they will say, well, at some point maybe in the future, but right now there is no business model behind this. But where it gets really problematic is when we want to send data that gets generated by these devices into the healthcare system. If we want to share it with a doctor, if a person with diabetes, for example, wants to send their glucose data to their doctor or to an electronic health record or to a hospital, they can't often do this. Often you have to take the data that's in your smartphone or in your cloud, export it into a CSV file, print it out, and hand it to your doctor. Now, that's not the 21st century standard of care that we would like to see. The reality, however, is that there is indeed a wall between the field of personal health and the healthcare system. So in comes the solution, of course, right? All we need is a standard. We, the Continua Health Alliance, and now, of course, the Personal Connected Health Alliance, we have been working on this already since 2006. We're an organization that was funded very much like on the model of other initiatives in this field, like the USB Alliance or the Wi-Fi Consortium, the people who make open standards for the connectivity of peripherals to hubs. We have had the same idea in mind. So 2008, we came out with our first specifications, with our first guidelines. 2010, our first devices came out. And since then, really, we've been struggling. We think our standards are good, our standards are sound, we renew them every year because there are new use cases, new developments in the field, new developments in the market. So we've also made them more robust, more official since 2013. We've been giving them away for free. Since 2013, we are also officially recognized as the ITU standard, ITU H810. And we offer, of course, to our members source code, test tools, and technical support, but we really invite every organization, every company out there to use it. It's available for free. You can download it from our website. Now, where's the and of course here's the scheme, the world according to Continua, if you will. You have the devices on the left-hand side. You send the data in a structured format that is already complementary, that already complies with the standards that are used in the healthcare enterprise. We're referring to eHealth 7. We're building on IEEE standards. We're taking existing standards by the source, existing standards and make them fit for purpose. Stephan mentioned that we're a profiling organization. In that sense, we very much work like IHE. And so our standards, we think, are robust. And it's just that they're not using it. We face the challenge of adoption. And the challenge really is a chicken and egg situation. We have the situation that we have so far a lack of demand for interoperable devices. Therefore, not as many devices are available as we would like to see. And as a result, therefore, a provider or a healthcare system that wants to mandate our compliance with Continua can't really buy that. And this is really where then the device makers come back to me and say, well, where's the business model? Why should I go to Continua if there is no demand? And so another round of our misaligned incentives ensues. I do see light, and I do want to leave you, and I want to share with you a sense of hope there. We do think that, particularly in Europe, there is now a number of countries and a number of providers, regions, and member states that are waking up to this opportunity, because we have in Europe public health systems that promise universal coverage, that are trusted by citizens. They're also, like everybody else, under pressure to save money, to become more efficient, and they're also under pressure from their citizens and patients who want to share their data with their healthcare system and who do not understand that this is still not possible. They are now investing in eHealth and telehealth. Some of them are more advanced, as we've heard this morning. Some of them need a little bit more space, more time, but they are building electronic health records, repositories of health information, and they would like to make that connection, overcome those barriers. They require data to be sent along open standards. We heard this morning of a trend, and I just want to build up on this. Many of you may have been here this morning when Erik Gerritsen from the Netherlands and also Tapani, I think, was mentioning the Finnish record. there is a pressure of patients that want to share their health data. Patients are the most underutilized resource in our healthcare system. People want to share this kind of data, and I think the recent European Commission the consultation has borne that out. And so we see now in many countries, in many regions in Europe, healthcare systems respond to that. In Catalonia, we have the HC3, which is a electronic health record system that's been in force and in place since 2010. We have in Finland, I think Tapani mentioned it this morning, Kanta, and in a few weeks' time they're going to launch the My Kanta service, where a personal element will allow citizens to share their data. And of course, as Eric mentioned this morning, with a beautiful animation and a beautiful little video, MedMai is coming in the Netherlands. These are the canaries in the coal mine. More of that will follow. And we see, and these are my personal heroes, in Catalonia now, they have for the first time last July, just a few months ago, said that if you as a citizen, if you as a maker of a glucose meter want to enable your customers to share your data with the healthcare system, you really need to do this with the continual guidelines of the Personal Connected Health Alliance. So these people are giving me hope. We think that more of them are on the way. I'm not going to go through all of this. This is a little map of many countries and regions that are looking at continual adoption. I invite you to take a look at our continual adoption playbook or download it from our website. And of course, I'm available to you for any questions that you may have. We also have a little stand over at the Wearable Technologies booth, and I'm going to be there until tomorrow afternoon. Thank you.
Thank you, Michael, also for rushing a little bit through this one. So how does Estonia also use continual profiles?
Yes, to a certain extent. But we are working closely with the mentioned task force where PCH Alliance is a member. So, yeah, that will be the answer at this point.
Ein is a professional politician and a wonderful politician. Politicians don't like taking risks. They don't want to make a decision until it is important, until it really becomes an issue. We see when we're looking at the European map, we see those countries and regions really looking very thoroughly at Continua when they're ready to integrate devices. There are quite a number of countries that are on the way there, and also regions. In Spain, it's the regions that really set these policies. And I think Estonia will come to us, I think, when you're ready. And I think, from what I understand, we're not quite there yet. But we will get there in time.
Good, but let's go back a step now. Thank you very much. Now we have the interoperability domain. I think it has been extremely well covered with all the last three presentations. Let's go back to the area of consent, data ownership, and so on. In Estonia, how is it in practice? The data which is in the, to my understanding, patients in Estonia can access their own health records normally. How is it regulated in Estonia for giving access for research? Is there a default, opt-in, opt-out?
Well, we have mixed systems, so that the basic old school informed consent is still working. The Estonian exception, though, is that we can use digital ways to ask this consent, which is we have patient portal, which has data for 99% of our citizens, and it is possible to use that digital platform to easily and also dynamically facilitate these kinds of consent. But at the same time, we just passed through a year-long process which involved Data Protection Agency and the Ethics Board of our National Health Information System, which now, after 2 series of redesigning of the process, have given their permission for full secondary use of data in our National Health Information System, which basically contains all data from primary care or hospital network. But again, so that there is kind of combination of pre-authorized informed consent in certain research projects. For others, it is possible to mandate it just by going through the ethics board. So effectively, it is a service that we have started to build. And I know that Finland is going the same way, that there is one-stop shop to get access to all the data. But it is not, the data is these days is not, this is junk somewhere, in a cellar, and then you take it and then you work with it. It really needs processing, and this kind of service is what we have only started to build this, and this, I believe, is the responsibility of the government to provide this kind of service.
Okay, thank you. Are there any recommendations on this matter by the European Institute, Veli? On patient consent for secondary data use?
Yes, the European Institute for Innovation through Health Data is working on these issues. And
the microphone on? Okay, ein bisschen lauter.
And especially related to clinical research. Not at the moment that much regarding reuse of electronic health data, but this is also included in the ethical guidelines and code of practice of the Institute. And we are putting forward such guidelines which are available for reuse by anyone who is interested. And of course, I will immediately check after this meeting with the president of the Institute, Deepak Kalra, and the people working in the information governance task force of the Institute, whether they have already signed the Digital Health Society Declaration and have joined the respective task forces there as well. I will immediately recommend this to happen, but it may have happened already.
Stephan, if I may, I just recalled an example why this service approach is the only way to go. Well, we have National Genome Bank since 2001. We have 5% of adult population who have donated their blood, which is now genotyped and linked with all the possible health data, and the research groups there publish on a weekly basis in Nature and Science, and wonderful science is being done. Now, in one of the research projects, they discovered that certain group of patients who even didn't have to use the genetic data. It was 4 pretty standard blood tests, which predicted 5 times increased probability of dying in the next 5 years, without any specific indication of what the diagnosis might be. Now, this was done in a research project. There's a very different kind of ethics that we reached there. So we discovered something that we didn't intend. At that point, all the study subjects, the samples were de-anonymized. So we didn't know at that point who those patients were. So in principle, we do have the service. Well, again, this is kind of tedious process when you can go back from genetic data to the individualized data. But that was a long debate. So what shall you do? First, how you approach the people and tell them, well, we know that you will probably die in the next 5 years, but we really don't know why you're going to die. And then you have to offer them some sort of a service. But if you don't tell them, that's a different kind of ethical question. So again, we are only starting to discover what kind of ethics and the consent around that is needed to be, because people also have a right not to know their future risks.
Oh, very true. Thank you for this interesting example. How is it dealt with in the Smith project?
In the Smith project, we actually have put the topic of consent management on the national level, because we have a working group from the National Steering Committee, and the National Steering Committee, they make a proposal how to deal with it. So actually, it's an ongoing process at the moment.
Thank you. Okay, any questions, remarks from the audience?
The European community will learn from Estonia and with data management, ethics, and so on. I think Estonia is a small country, but it has very fine programs in this area.
Well, thank you, but I can immediately tell you, you should check also what the Ireland is doing, what Finland is doing, what Denmark is doing. So we are, trying to keep on track on a weekly or at least monthly basis, because there are many countries, tends to be smaller ones, I don't know, but sophisticated principles, but in some cases also the technological processes behind that. So the area is moving fast, and it is exciting times to live on.
Yes, indeed. And I think okay, we did not so much discuss in detail what is done with big data, which is anonymized from the beginning, or maybe your analysis were so. So it's amazing what can be now aggregated, for instance, from the wearable devices. So I've seen in the US that they can already break down activity levels. So Withings, formerly Withings, now Nokia. They can break down activity levels through all the states of the US simply by the big data. A very simple example, but this is reality today. So we will see a lot of those stories to happen, and the debate on the right to know and not to know. I think that's something which will come back in many different ways to us. Okay, so obviously we are trying to close the panel, but any final remarks wanted by the panelists?
Just as one, Withings is a thorn in my side, like many other these consumer devices, these consumer device companies. They of course do not structure their data along open standards. One thing about big data that always puzzles me is that the research is always sponsored, comes out from one of these companies that have a walled garden, and of course have enough data that they can use it. But shouldn't it be a matter of collecting the data along open standards, storing it maybe at a government level, and then making it available to researchers and people outside this one specific company? It's a wonderful that this exists, but it really we're staying within those walled gardens if we don't break this open.
Okay, allow me an immediate comment on this, because this is we had an event in July, and Sebastian was actually, we were co-hosting it, and it's amazing to see how many of the German federal Länder are considering really to become active in this domain and to become let's say at least the legal host of electronic healthcare record data. So that's an open door. So, Veli?
Thank you. What we didn't have time to discuss was the issue of is it really so easy to use and reuse this data, and how can we make sure that all the stakeholders along this process are on board and equally incentivized and motivated? And these are two issues where the Institute is putting a very strong focus on. One thing on developing concrete tools, helpful tools, analytics tools as well to analyze the quality of health data at hospitals, GP offices and others, and another focus on providing the local people with instruments, strategies, how to improve the data quality, but also how to incentivize the stakeholders and take them all equally on board.
Okay, thank you.
Yeah, for the Smith Consortium, I can say that I think that the initiative will bring benefit for the patients, and I think it will also bring benefit for the patient in the other consortia, of course. We collect many data, a lot of data, but we have to develop the right tools and guarantee the quality of those tools. If we just develop it and cannot guarantee that the quality of the prognosis, for example, in the ASIC use case, is guaranteed for a long time, then those tools are useless. We have to guarantee the sustainability of those tools, and we must develop the right tools.
Okay, thank you.
I could only repeat basically what I said, that the technology and the legal environment, but also the data governance part, should always consider citizens, so the individuals about whom the whole thing is as integral partners in the whole exercise. So the technology shouldn't be there only for the researchers to have even better opportunities to answer sophisticated questions, but actually from the very first moment understand and engage. Think innovatively. In different countries, the engagement can be different. I mean, we have very transparent system. It's easy for us. England found their way. I'm certain in Germany you will also find ways. But if you bring patients and citizens together from the very start, you will get your trust level up much, much quicker.
Okay, thank you. Okay, thank you all the speakers. Thank you the audience. A little bit smaller now than at the beginning. Okay, thank you Ein. Thank you Michael. Thank you Veli. Thank you Oliver. Okay, so I close here and we will we will continue in a few moments with the session Transatlantic Perspectives from Educated the Health Workforce for eSkills. And in this session we will also have a remote presenter from the US. So hopefully you come back very soon.